Hey there, hi everyone. Welcome back for part 2 of our I Care for Your Brain lecture with me, Dr. Karen Sullivan, where we're going to talk tonight about ongoing connections between essential tremor and Parkinson's disease. The way we usually talk about these two complex neuropsychological disorders is how they are different. But in recent months and years, we've started to talk a little bit more about how they are the same. And that's important because I want my folks in the ET community to understand how some symptoms that they could be having over decades could be evolving. But we also want to really focus on empowerment. So my big thing is, if you know what it is that's happening to you, it's a lot less anxiety provoking. You can be more in charge of your own body and in your own medical care, because now you are advocating from more of an informed point of view. So in the last 5 years, we've come really far with pushing the understanding of what essential tremor is. And we owe this to the fields of epidemiology, clinical neuropsychology, neuroscience, clinical medicine, and finally we're challenging the idea that ET is an isolated disease, an isolated disorder that has a monosymptomatic presentation, right? How long have we heard benign essential tremor? You know, it shouldn't get worse, it's just a tremor. Well, thank goodness we are moving towards a much more validating scientific explanation of what essential tremor is, above and beyond an action tremor that runs in families. As many of you know, I am very interested in learning and communicating with you all about the non-motor symptoms of ET. Thank God we have finally validated that ET has sensory, cognitive, and emotional symptoms that are just as brain-based as the tremor. And that's what I have focused on in some of my research that I've shared with you here on the weekly free brain health lectures, but also we put together a really big effort a few months ago in our Essential Tremor webinar that's 4 hours long. I mean, it almost is to the point where you're like, okay, I think I've learned about all I can possibly learn about this. Anything that's out there that I thought was of interest in the scientific literature, I passed along to you. And I hope it's a very practical way of understanding and managing the non-motor symptoms. And so as we go through our lecture tonight, I'll have the link on here for the ongoing 50% off discount if any of you haven't watched it so far. So the way ET has been getting pushed forward in recent years is really through this concept of Essential Tremor Plus. And if you haven't seen my free lecture on that, please go through the Facebook archives or on the YouTube page, where we finally have a category for people who have more than just action tremor. And so now we validated some non-additional motor symptoms, but also this idea of word finding deficits, emotional dysregulation issues, eye movement deficits. We're recently putting some hearing loss on the map. And if you recategorize all the people that we have with ET according to this new diagnostic criteria of Essential Tremor Plus, they think up to 83% of you would be recategorized as having ET Plus. So my personal opinion is that we're very new in this and we're just starting to put better names on things, but I think ET Plus is a placeholder, as we've said, not a grave marker. So we can't assume once someone is in the ET Plus category that no more of their symptoms should be worked up. We shouldn't assume that we've got it all totally figured out. I think it's a great, important first step, but if 83% of the people with a certain disorder would actually meet criteria for a differently named disorder, it can't be that we've got it figured out, right? So I think ET Plus is much more the norm. It's more likely most people that have it, and that's why I have deemed it so important to communicate with you all out there in the ET community what this literature has to say. So, like I said at the beginning, most times we have focused on how ET and PD, Parkinson's disease, are different. And that's mostly because of the bad history of misdiagnosis. So 1 in 3 people who go to a doctor with a tremor get misdiagnosed. That's pretty bad. I think a lot of you probably have your own life experience, your own diagnosis journey, which is certainly traumatic and stressful and takes much too much time, and much too much time is wasted. So most people who get misdiagnosed as having ET actually have Parkinson's or something called dystonia. So in the first part of my lecture, what I focused on is I kind of called it like the old school and the new school way of thinking about ET and PD. And we talked about how this is the way we used to think about it, but really if you're up on the literature today, it's much more that there's points of connection. So recent research has really focused on what are those similarities where ET and PD connect, and that the idea is it illuminates both disorders. But we also have an interesting insight with the folks who develop over time, who have ET, who go on to develop Parkinson's. So I want to give a disclaimer at first, because I know when some of you hear this in the ET community, it's like, are you kidding me? I really have to think about developing something else. Well, most of you will not develop Parkinson's or any additional motor symptoms for that matter. Things like the bradykinesia we talked about last time, which is a general slowness. There is rigidity of muscles, postural instability. In general, we don't think that this is common, but if you have ET, you're more than 4 times likely to develop PD than those without ET at baseline. So you better believe we think this is an important thing to talk about. So there's no research study, though, that goes in the other direction. So I wanted to know, well, how about if you start off with PD, how likely are you to get essential tremor? No data out there that I could find, and they think that there's a reason for this, and this is because it's really hard to diagnose ET in someone that already has PD, but there are a couple distinctions. So the big one diagnostically has to do with alcohol. How many of you have been told to have a drink at the neurologist's office, because alcohol really does calm the tremors in essential tremor? It doesn't really do anything to Parkinson's disease. We also know that you're much more likely to have a head tremor, you're much more likely to have a vocal tremor or difficulty with writing when you have essential tremor and not Parkinson's disease. So, but there was one study in 2007 that did talk about that there were a couple patients that had PD that went on to develop ET, but it was like a case-controlled study, so there's no real like epidemiological information, like we know, like I said before, about how you're more than 4 times as likely to get PD if you have ET. There's no statistic for that in reverse. But there is some new research, and that's really the focus of my time with you tonight, is to focus on folks who actually do develop both, okay? And that's really important. So why would that be important? Well, not only for your sanity, knowing what your body and brain is going through, but there are medication options for Parkinson's that we don't have in essential tremor. So there's about 13 common medications for Parkinson's, not nearly that many for ET. In general, PD is much more well-funded, much better researched, much more publicized, which I think is a very interesting question to ask why that is, considering if you just look by the numbers, there's actually many, many more people with essential tremor. So the focus within this world of ET and PD and how they connect is on something called prodromal symptoms, and that's the earliest possible symptoms. And this is important for early intervention, which the more you start to understand about the state of neurological issues nowadays, the real focus is on early diagnosis and early intervention. And in fact, what we really need in the world of brain health science is way earlier biomarkers than we can pick up on clinically. And that's coming from someone who has dedicated her life to clinical symptoms, manifestations of brain issues. But the truth is, by the time most neurological disorders reveal themselves clinically, like with a symptom of tremor or of memory loss, the pathological disease processes behind the disorders have been going on in the case of Parkinson's for at least 10 years. In the case of Alzheimer's, 30 to 40 years. I have not seen any data to tell us what's happening underneath the iceberg, so to speak, in essential tremor. But gosh darn it, by the time we can see these things clinically, an outward manifestation, there's already been significant cell death in, for Parkinson's, we know it's the substantia nigra and the neurons that make dopamine. In essential tremor, we know it's those Purkinje cells that make GABA. So we know the underlying mechanisms, we just don't know how to ID people early enough so we can actually really get in there and make some disease modification changes. So, by the time folks with Parkinson's, just as one example, have the first 2 prodromal symptoms, so again, remember, these are like the very, very earliest things a doctor could ever pick up on, that you could pick up on. In Parkinson's, we have constipation and we have loss of smell, loss of taste. 90% of people at the time of their diagnosis of Parkinson's, when it's accurate, already have those symptoms, okay? So what I wanted to know was, what are the prodromal symptoms in ET as it stands alone? Couldn't really find those. What they really just have always thought about is it's a monosymptomatic presentation, it's bilateral action tremor. So to me, we just haven't asked the right questions clinically. We have no idea. Let's just say you start to develop your ET in your 50s. We have no idea what's happening in your brain in your 20s and your 30s and your 40s. Just that work hasn't been done yet. So we have an opportunity when we start to study this subgroup of people that have ET and PD. What can we learn from those people about what they first start to manifest in terms of Parkinson's? So I promised you last time that we were going to go through all the literature that was available, and that's what we're going to do. It's a very small literature. It's not as data-driven as we would like, but by all means, I think you should know this information. So let's get started. The first one we're going to talk about is jaw tremor. When you have ET, you know it can set up in your arms, it can set up in your head, in your voice, and for some people, they can have it really strong in the jaw. Folks who have ET in the jaw, it's typically thought maybe 8 to 18% of people will develop that in ET, but these folks tend to have more severe clinical symptoms of ET. They tend to have tremor more widely distributed across the body. It's bad in the jaw, it's the worst in the jaw, but all through the body has a lot of tremor. And it's thought that underlying that jaw tremor is something called Lewy bodies. And we introduced this a little bit before. These are proteins that can unfortunately kind of clump in brain cells and over time kind of strangle them and lead to the death of the brain cell. And that we know is at the heart of Parkinson's disease. And that's one of those things, old school, we used to think they were very different, that never happened in ET, okay? Well, now we actually know that there is if we start to look at autopsies, folks with ET are 7.5 more times likely to have Lewy body collection in their brain. So there's something there. We don't quite know exactly what it is, but we do know when we start to really test people for ET for those non-motor symptoms, we are picking up on a reduced smell deficit. Now just think about that. How many of you out there listening to me who have ET, who've had it for years, who've had it for decades, have ever heard that reduced smell is a part of your disorder? I'm very curious to see what you all have to say. So to me, that's a perfect example of why we need to validate non-motor symptoms, because what if you don't know that's a part of ET and your husband's always like, how come you don't smell that garbage getting ripe over there? You know, you don't seem to wear that perfume I gave you or whatever. That to me is an added layer of a form of suffering. If you don't know what is happening to yourself, it gets distressing and confusing. So that's really what I tried to focus on in that 4-hour webinar I was talking to you about before. So when they start to look at this subgroup who has ET and PD, one of the things they found is that the people who have both have more resting tremor, okay? So in PD, the classic tremor is a resting tremor. When your hands are at rest, the classic pill rolling tremor, you can see people kind of go like that. With ET, it's the opposite. It's an intention tremor, and it's when you go to do something. You could be totally relaxed and fine, no tremor, but then when you actually go to, you know, put the spoon in the soup, when you go to touch your nose, when you go to put pen to paper, that's when there's an action, and that's when the tremor really comes out. So resting tremor is something to just kind of keep our eye on. Another motor symptom that's been implicated is asymmetrical postural tremor. And so this is from a very small group of people who went on to develop PD when they had ET, just 13 people. And they noticed that almost all of them had late onset asymmetrical postural tremor. It is a mouthful. So this is a classic example in neurology how something can sound super complicated, but if you just explain what it is, it's not only easy, but you can figure this out on your own without a doctor's help. So all you have to do is sit in a chair, put your arms out in front of you, wait about 20 to 30 seconds and see what happens. What they're saying here is this would be the postural position. So it's anytime your limbs are outstretched when gravity is going to have an impact on them. And what they're saying here is one hand more than the other starts to show a significant tremor. Okay, so in these people, that's what they found to be one of the markers. The next candidate is a specific sleep disorder. This is REM sleep disorder. And this may be one of those early prodromal symptoms. So REM means rapid eye movement sleep disorder. It's called a parasomnia, which is a form of a sleep disorder. And basically it's acting out your dreams. It's not having the brainstem working properly, so you become paralyzed during REM sleep. You actually start to do dream enactment. So this can be anywhere from just moving your hands. A lot of people kick and punch. People ride bicycles in their sleep, and typically they don't know, so they'd have to have a sleeping partner to tell them. Typically comes to medical attention when people hurt themselves, or maybe they hurt a spouse. I have had patients who have broken necks because they have put their heads through walls when they were having REM sleep disorder. I've had plenty of patients who are advised to sleep in separate beds from their loved one because there's concern they could be physical violence, unintentional. It can also happen in other conditions like post-traumatic stress disorder. So again, you know, we want to look at data. So we actually have a little bit of data on this specific symptom. So in the regular population, people with no brain health conditions, 0.5% of the population would be expected to have REM sleep disorder. In Parkinson's, it's about 50%. And in ET, there's only been a couple studies, but it ranges from 10 to 26%, okay? So remember, I've taught you guys this before. It seems to me when I look at all this different research, it's like people without a movement neuropsych disorder are here. Parkinson's folks have a fair amount of symptoms, and ET's kind of right in the middle. So it's not ET. I mean, ET is not PD. There's certainly distinct entities at a certain point, but there's something there. There's some point of connection. A lot of things that folks have with PD, folks with ET have it, but in a more mild form. So what they looked at in their study is between people with PD, people with ET, and people with ET-PD, people who had both had rates of REM sleep disorder at 51%, whereas people who just had ET in this study were at 10%. So that's a pretty big difference. And the folks with ET-PD who had REM sleep disorder also had a resting tremor. So now we're starting to see, like, is this a syndrome? What is this we can build on together? Furthermore, folks who had ET-PD REM sleep disorder also had reduced scores on memory test. So you see, we're starting to get some information, but we don't yet have the expertise to more intelligently piece it together. Another factor may be family history. So people who had both ET and PD had a stronger family history of folks who just had ET. The next candidate is something called heart rate variability. This one, I did a fair amount of research so I could explain it well to you all, and I'm still like slightly unclear of what it is. But this gets back to autonomic symptoms. If you were with me for the first part of my lecture, I talked about these. These happen very commonly, we know, in Parkinson's. That's part of like what we ask for. Hypotension is a big one in Parkinson's. So when you stand up quickly, do you start to kind of go fuzzy and see black? In ET, what I taught you last time is that 96% of people report having one autonomic symptom at least, and the number one area is with urination, so difficulty starting to pee. Heart rate variability evaluates cardiac autonomic function, and basically it measures beat-to-beat variability. So there's a certain amount of rhythm that you should have in your heartbeats, and there's high frequencies and there's low frequencies. So what they have found is that people who have ET and PD together have lower frequency components. And all I wanted to know, Google, was what does that mean for people? And you could not tell me. All I could find was that it is related to an increase in depression, hypoglycemia, panic disorder, sleep disorder, asthma, fatigue, dizziness, and nausea. I don't know anything else beyond that, but if I find it in the research, you know I'm going to share it with you. This next one, I want you to file under don't get freaked out, but be well informed. There are some researchers that are starting to suggest that the long-term use of beta blockers in essential tremor could be something that increases your risk of PD. So this is based on a large registry study that came out of Norway. And this is really cool what they do. A lot of times in European countries is they just like make everyone in the country participate in public health research, and you your information, you know, having a socialist medical system, you can gather a lot of information about people and say what you will about people's privacy. It certainly helps science move along. So they had 4 million people data, and what they looked at is the association between some beta blockers, including propranolol, which I know of you all take, and the development of PD. And they basically found that there is a significant increase for people who, just normal people who don't have any movement disorder, take a beta blocker, they're more likely to get PD, or if you have ET and that's your medication of choice, you are more likely to develop PD. So you're not going to stop taking propranolol as a result of what I just shared with you, but you are potentially going to talk to your doctor about it, and you're going to be more informed when you go in there to have that next movement disorders neurology consultation. There's also one study that said, well, what is the cause then? What could beta blockers be doing? And one thought was that it could increase the risk of those clumpy proteins I was talking to you about before, which we know have a detrimental effect on the ability of the brain to produce dopamine. So it's kind of like, maybe that's the link there. Intriguing hypothesis. We certainly need a lot more studies to start recommending against propranolol. I just spoke with someone this morning who has ET during a consultation, and that's like the only medicine that's helped her, and it's been a godsend. So I'm certainly not saying to make any drastic changes, but I think you should know about it. If scientists know about it and it's in the literature, you better believe that I think you should know about it as someone who has it. So this is really just the beginning of understanding this connection between ET and PD. We are far from getting it right. We need a lot more high quality longitudinal studies that look at pathology, genetics, clinical symptoms. But really, I think the thing science could do better on is listening to people who actually live with these brain health challenges. That is why I choose to become a neuropsychologist, because we spend a lot of time, and I think as a group we are specialists who really appreciate the whole person approach, and we tend to be good listeners. We're psychologists at heart, and you know that that is one of the intentions I have by doing these brain health lectures every Wednesday, is I want you to know more about us as neuropsychologists, because we might just be the brain health partner you've been looking for. So there's so much information that is out there now about ET, about Parkinson's. It's my pleasure to bring high quality information to you. I'm very touched by how many of you have gotten in touch about the webinar and have let me know that some of you have said it's the first time anyone's ever really explained it to me, what's happening in my cerebellum and my Purkinje cells, and oh my gosh, that makes so much sense, why my anxiety is bad or why I can't find my words sometimes. So the validation is what means the most to me. So in the comments, you'll see that link there, and it's 50% off. We're probably going to take it down in a couple days, and that would be our pleasure if you would join us over there. So what are the take-home messages for today? If you have ET and you have a resting tremor that's developed, if you have one side of your body that seems to be getting significantly worse than the other side, if you have a loss or reduction in your smell, if your partner tells you you act crazy in your dreams, you act your dreams out, it's the time to bring this up with your doctor, okay? A neurological exam is extremely sensitive to Parkinson's disease. They can do a great job moving around your shoulders, looking for all sorts of subtle signs of Parkinson's. Advanced neuroimaging might also help you. So there's something called a DAT scan, that's a SPECT scan. This is advanced imaging that basically is a way to visualize dopamine being transported in the brain. In the United States, if you have Medicare, you are allowed one of these very expensive scans in your lifetime. I would imagine maybe it's a little bit more generous in other countries, but that could be something that ultimately could sort it out. Neuropsychological assessment would be the other thing. We can look for the patterns that we know happen in PD versus ET, listen to your symptoms, have a good hour with a provider to really have a chance to tell your full history, not have to like get through it in 10 minutes. So that's everything for today. I'm very pleased to have the distraction of being with you today. Not exactly an easy day to be an American today. Very difficult things happening in our democracy. So anywhere you are in the world, say a prayer for us that we get back on track. That's my political statement for 2021. You guys are awesome. Thank you so much for being here. I really enjoy this time together. I'll see you next time. Bye-bye.